Hello, and thank you for joining us. The Southeast Mental Health Technology Transfer Center is pleased to present today's webinar event, What It Means to Become a Certified Community Behavioral Health Clinic, or CCBHC. My name is Emily Moore, and joining me in moderating today's event is Dr. Benjamin Druss, Director of the Southeast Mental Health Technology Transfer Center. Before beginning, I would like to take a quick moment to describe the work of our center, followed by an introduction of today's speakers by Dr. Benjamin Druss. Please note that the work of our center is supported by a grant from the Substance Abuse and Mental Health Services Administration, or SAMHSA. And our center and the larger MHTTC network use affirming, respectful, and recovery-oriented language in all activities. The Southeast Mental Health Technology Transfer Center is located in Atlanta, Georgia, at Emory University's Rollins School of Public Health. We are proud to serve the 8 states of HHS Region 4. Our expertise in public health programs, systems, research, and evaluation provides a unique lens through which we can address mental health priorities. The goal of the Southeast MHTTC is to accelerate the adoption of evidence-based mental health programs by providing training and technical assistance to Region 4. We use a public health approach to build leadership capacity and to provide mental health trainings and resources to providers, agencies, and communities across the Southeast. We encourage you to visit the Southeast MHTTC website to learn more about our center and upcoming event. A brief reminder that today's event is being recorded and will be made available on our website in a few days. I'd now like to turn it over to Dr. Druss so that he can introduce today's speakers.
Thanks so much, Emily. We're really excited about today's presentation. The 2 speakers will be Rebecca Farley-David and Jonathan Brown. Rebecca Farley-David is Senior Director of Public Policy and Special Initiatives at the National Council for Behavioral Health. She's worked to advance and support the CCBHC model for more than 10 years, from introduction of the original authorizing legislation through implementation of the demonstration and expansion grants. She currently oversees the National Council's CCBHC Success Center, an initiative to support states, clinics, and other stakeholders throughout CCBHC implementation and ongoing operations. Jonathan Brown is a Senior Fellow and Director of Behavioral Health at Mathematica, where his work focuses on improving the quality and outcome of behavioral health services. He directs an ongoing national evaluation of the CCBHC demonstration for the Office of the Assistant Secretary for Planning and Evaluation, and recently completed a national evaluation of the Primary and Behavioral Healthcare Integration Program for SAMHSA. He provides evaluation-related technical assistance for state Medicaid demonstrations and has worked with states, health plans, consumer organizations, and community mental health centers to develop and use behavioral health quality measures. Dr. Brown is a native of Alabama and currently lives in Atlanta. With that, I will pass it over to you.
Hi, good morning, everyone. Thank you so much for having us with you to talk about the Certified Community Behavioral Health Clinic model. Before we get started, I think we'd like to just begin with a quick poll of folks who are on the line to understand a little bit about your experience with CCBHC so far. So if you could just take a moment to tell us if your organization is currently a CCBHC, either through the Medicaid demonstration or an expansion grant. Perhaps you aren't a CCBHC yet, but thinking of becoming one, or maybe in a mode where you're still learning more before deciding whether to pursue it. And if none of these answers apply to you, I think we'd also love to just hear you chime in the chat with, what is your status relative to the CCBHC program or your thinking. So we'll give folks just a moment to submit their answers. And when we've got a high enough response rate, I think we can go ahead and close the poll. So let's take a look at the results. All right, so it sounds like about a quarter of you are already CCBHCs, either as the result of receiving an expansion grant or participating in the CCBHC demonstration. For those of you that are already a CCBHC, some of this information may be familiar to you, although you might get some new ideas about some approaches that clinics have used elsewhere. Looks like about 20% of you are in that planning phase, planning to become a CCBHC at a future point, and the majority of folks on the line are still learning more. So we're glad to be able to provide you with information to help inform some of those decisions and just help you explore this model. I think we'd welcome questions at any time in the chat. We will be saving all questions until the end, but please do engage with us through the Q&A function to let us know if you have any questions as we go along. All right, so with that, I will share some slides. All right, so we want to start by providing some context and an overview of CCBHCs for those who may be less familiar with the model. CCBHCs are a model of service delivery and payment built on the idea that if we want to expand and improve care in our mental health and substance use system, we need to actually pay for the activities that make those goals possible. For generations, reimbursement rates for mental health and addiction treatment have been set so low that clinics find themselves quite often trying to cobble together funding from multiple different sources simply to keep their doors open and make payroll. We also know that there is an incredible workforce shortage that is particularly devastating in the safety net, where low reimbursement often inhibits organizations' ability to offer competitive salaries and to recruit and retain staff. And so, and furthermore, there's just a lot of work that clinics do that we know is really critical to improving outcomes that isn't billable under traditional insurance models. And so CCBHC really reimagines all of that. It establishes a national definition regarding the scope of services, the timeliness of access to care, staffing models, and so on, that all clinics who get this designation have to meet. I think that national definition can really be considered as raising the bar on the scope of services available within communities. Most clinics around the country offer some combination of the required CCBHC services. Very few offer all of them. And so as a result of this national definition, we've seen clinics making really big improvements to the services available within their community, and also partnering with other organizations in new ways that extend the availability of other services to more clients. The program also comes with standardized data and quality reporting, which is really helpful for states and payers thinking through, how do we know what sort of value we're getting for our investment in this model. And for clinics that are able to meet that criteria and get certified, it comes with a payment model that covers the anticipated cost of opening access to new patients and new services. And I think most critically, that payment model does include those non-billable activities like outreach, care coordination, technology, and many other things that we know to be critical, but far too often are, just simply have no source of funding within our system. So there's currently 3 implementation options for clinics or states looking to adopt the CCBHC model. There is a Medicaid demonstration program that is ongoing. That demonstration program began in 8 states. Currently, it has expanded to 10. If you're not in one of those 10 states, the option for becoming a CCBHC would be through a pot of federal grant funding that flows directly to clinics, enabling them to implement the CCBHC model over the 2-year grant period. That grant funding, it's really helpful, because it does cover many of the costs of being a CCBHC, but it's not sustainable because it is a grant. And so, we see the grants really as a springboard into statewide implementation of CCBHCs in Medicaid through a waiver or a state plan amendment. If the Medicaid demonstration were to expand to additional states, that could be another option. But in those non-demo states right now, the primary option available for statewide implementation would be through a Medicaid waiver or plan amendment. And we'll come back to these options at the end before I turn things over to Jonathan. I just want to spend another minute kind of clarifying the difference between the expansion grants and the Medicaid demonstration, because there's a lot of confusion around this, and rightfully so. It is a confusing differentiation. The Medicaid demonstration was the original, was where CCBHCs were originally established. As I mentioned, that demonstration is only open to 10 participating states. In contrast, the CCBHC expansion grants are open to individual clinics in all states. So if you look at kind of the structure of each approach, sorry, I don't know why there is Colorado specific information in this slide. My apologies. If you look at the states that were originally, or the original kind of implementation of the CCBHC model, it was founded around the sort of the state being the arbiter of the CCBHC certification and the payment. The state decided who got certified. The state established the payment rate with those clinics. And so there's significant state involvement administered by those state Medicaid and behavioral health authorities. The expansion grants are administered by SAMHSA, and there's not really any involvement of the state in those grants. Again, we see the grants as a springboard into state implementation. So we certainly encourage grantees to work closely with your state, let them know that you intend to go after a grant or have one, that you're interested in exploring sustainability options with them. So certainly, although states are not don't have a formal role in those grants, for grantees, there's a great opportunity to engage with your state to try and build this program into a longer term initiative. And then in the demonstration, CCBHCs do receive a special Medicaid payment methodology that's known as prospective payment. We'll talk more about it in a moment. But it does, because it's a Medicaid payment, it flexes with the number of enrollees or the frequency of their encounters. In contrast, the grantee CCBHCs receive a fixed pot of funding over those 2 years. They continue to bill Medicaid and other payers per usual, and grant funds, as you all know, don't flex in quite the same way that that Medicaid does when there's changes perhaps to the level of need among clients or the number of clients enrolled. So both are really important ways of implementing CCBHCs, but there's critical differences between them. And I think together, both can build towards a more nationwide implementation of the model. Let's take a look at what the status of participation in the model is nationwide. You can see the demonstration states are marked in dark blue. I want to point out Kentucky here is one of the newly added CCBHC states. They'll begin their demonstration in the late summer or fall of this year. And then the states in light blue are states where individual grantees are operating. To dive more deeply into the Southeast region, you can see here again, there's one demonstration state. There are 5 states with individual grantees, and then there are 2 states with no CCBHCs yet. But I certainly know that there is interest among clinics in both states, and I expect that we will very shortly see some grantees there as well. All right, so let's talk a little bit about CCBHC criteria and payment. I mentioned that CCBHCs have to meet a standardized array of criteria. Those cover 6 domains. You can see them listed here. I'm not going to dive deep into all of these domains. We'll talk in detail about some of them. I'm happy to answer questions about any of it. However, as we look at the CCBHC criteria and what CCBHCs are doing, under this model, I do want to make the point here that by and large, CCBHCs aren't necessarily coming up with innovations that no one ever thought of before. What they're doing is securing a funding source to make those innovations possible and sustainable and implement more of them. So you hear me talk a lot about CCBHC successes, and and I certainly don't mean that to imply that non-CCBHCs are not doing many of these things. It's just that they struggle harder to do it without that financing there, to fully support those programs or activities. And so in that way, the CCBHC model brings together all the best of what clinics are doing throughout the nation in the safety net to provide access to mental health and addiction care, and sort of combining them into a defined model that has a payment that comes along with it to support those activities. So let's take a look at the CCBHC scope of services. There's 9 required types of services that CCBHCs have to provide. You can see them listed here. Those in blue must be delivered directly by the CCBHC, and those in green can be delivered by a CCBHC or a partner organization known as a DCO. Because CCBHC wasn't a clunky enough acronym, we added DCO into the mix. And so together, the CCBHC and their DCO or their partner deliver all of these services in their community. Quite often, what we'll see is the CCBHC delivers some amount, for example, of peer support or primary health screening and monitoring, but they might also contract out to another provider to supplement what they do. So you start to see how even when CCBHCs are expanding their own services, they're also strengthening those partnerships with other providers in the community. Substance use disorder treatment and specialty mental health care are 2 really big areas where we see this happening. So a lot of CCBHCs, for example, are working with DCOs to deliver specialty child and adolescent focused services. A lot of them are offering a minimum amount of substance use service on site, but then also contracting with substance use providers to, to supplement that. So we're seeing some really exciting partnerships happening across the healthcare system. And when it comes to crisis services, CCBHCs are not meant to duplicate existing crisis infrastructure. And so in areas where there is a statewide network of crisis response, the CCBHCs can contract with those crisis providers rather than trying to rebuild what already exists in their community. Care coordination is another critical feature of the model. I think most states and clinics that I talk to, that are participating in this, call the care coordination features of this model one of the most game-changing aspects of it. The model does require partnerships or care coordination agreements with a number of entities that you see listed here. That includes both some of the usual suspects in the healthcare world that you would expect. So FQHCs, primary care providers, hospitals, and so on. It also includes providers of social services across the spectrum, folks who are maybe not necessarily healthcare providers, but who touch the lives of individuals served by CCBHCs, and who should be coordinated with in order to make sure that that individual is receiving the right care at the right time in the right setting. And so CCBHCs are required to partner with schools and child welfare agencies and criminal justice agencies and so on. I'm sure Jonathan could tell you more about what this has looked like in practice, but really CCBHCs are thinking even more expansively about their care coordination partnerships and partnering with entities well beyond the required minimum list that was set out in the statute. So we just see some really tremendous strides towards improved care coordination and integration of services across that spectrum of entities that engage with individuals served by CCBHCs. The payment model for all of this is known as a prospective payment system. And if any of you are federally qualified health centers or familiar with the federally qualified health center payment, this will be familiar to you. To establish the CCBHC payment, the CCBHC completes a cost report that basically articulates the entire cost of doing business as a CCBHC, not only historical costs that you're going to incur based on what you've done previously, but also your anticipated costs based on the services or the staffing that you're adding, the influx of new clients that you anticipate you will serve. And so all of that, I like to think of this as like a soup pot. So all of the costs that go into operating your clinic, and that includes both direct and indirect costs, both billable and non-billable expenditures, it all goes into the soup pot. They're like the ingredients in the soup. And then every time an encounter happens, and this could be on either a daily or a monthly basis, you take a ladle of soup out of the pot. And that is your payment for that encounter. Now, the payment is going to be the same regardless of the volume or intensity of services delivered on that day or in that month. So if you have someone who came in on one day for, let's say, a med check, and that was all, the payment is going to be much greater than the actual expense of caring for that client on that day. If the client comes in and needs a med check plus a meeting with their case manager, plus a group therapy session, plus other services, you still get the same payment. And so the clinic might not make enough from that single payment to cover that higher intensity client on that day. But over the course of a year, if you've done a really good job estimating your costs and your number of encounters, the payment over a year will roughly cover or roughly equal what it costs to deliver those services to that population. And again, the states that are in this model have the option to choose an encounter that is calculated on either a daily or a monthly basis. So with a daily one, you get one encounter or one payment per day that an encounter occurs. For a monthly system, you would get one payment per month in which an encounter occurred. Both have their pros and cons. States are using both quite happily, and clinics report being very satisfied with the ability of this prospective payment system to fully support their activities as a CCBHC. So again, I just want to point out that this payment system does, although you wouldn't bill on a, for something like an outreach worker that had an encounter or had an engagement with an individual out in the community, for example, you don't receive a payment for that. The cost of your outreach worker is built into, right? It's one of the ingredients in the soup. It's built into that rate. And so every time you do draw down an encounter payment, it is covering in some way the cost of all those non-billable things, the care coordination, the outreach work, the technologies that support care access, right? Any number of other things that historically are quite hard to fund go into the soup, go into the cost report. They are part of that payment. So as we look at what this model has supported, what this financial model has supported, and I'll be talking primarily about the demonstration because, again, the grants are very different. The grants are a two-year pot of a fixed sum of money that is designed to help you do all of this work, but it doesn't have the same flexibility as the Medicaid prospective payment that I just described. So looking at the clinics that are part of that Medicaid prospective payment system, 3 years in, almost 4 years at this point, that payment model has supported increased hiring and recruitment. Clinics are able to offer more competitive salaries, which has enabled them to fill vacancies, expand staff positions, and reduce turnover. The clinics have spent a lot of time redesigning care teams in this more flexible environment where you are billing only on a daily or a monthly basis rather than in units of service. You are free to use your staff in different ways. So for example, maybe your psychiatrist has more time to do things like consults on shared patients with other providers, work that's not billable, but again, which is built into that payment rate. Clinics are rethinking who is on the care team and really re-envisioning what a care team should look like and how it should function. CCBHCs have been able to improve access to care. And when I say that, I'm talking about access along several dimensions. They've been able to serve more clients overall. So across the 8 states that were the original demonstration participants, over the first 2 years of the program, we saw an average 25% increase in the number of people served. By and large, these were people who did not previously have a source of care. So you can, they're bringing folks with an unmet need into treatment, often for the first time. The clinics have essentially eliminated wait lists. The longest wait that clinics report to us for services would be around 10 days, but much more common is same-day access. Half of CCBHCs do offer same-day access. And clients are able to access a greater scope of services. So clinics that previously perhaps only offered mental health treatment are now expanding more into addiction care. Clinics that may have only served adults are now working with children. So we're just seeing access to that greater scope of care among CCBHC clients. CCBHCs are launching new service lines to meet community needs. Quite often, those services are being deployed outside the 4 walls of the clinics. I was reading just this morning, rereading the Mathematica report that Jonathan's going to talk to you about, and recalled that 96% of CCBHCs are offering services somewhere out in the community. I already mentioned the improved partnerships that we're seeing with schools, primary care, law enforcement, hospitals, and many, many others, which has been a huge benefit of this program. And the result of that better care coordination and the improved accessibility of care is a reduction in hospitalizations and emergency department visits that states and clinics are reporting to us, as well as improvements in physical health indicators. Certainly you can see the impact that this payment model and delivery model has had on these communities. So looking ahead at what's next for CCBHCs, we do see broad bipartisan support in Congress and the administration. The Medicaid demonstration has been extended through, I'm sorry, there's an error on this slide. I'll correct that before the slides go out to all of you. The Medicaid demonstration has been extended through September 30th of 2023. So there was a 3-year extension passed just in December. There's continues to be strong support in Congress for expanding funding for CCBHC expansion grants. So we do anticipate future rounds of funding for those expansion grants. If you're thinking about going after this, there will be more opportunities. And as I mentioned before, states can implement the model without congressional action. Texas is the state that's farthest down that road. They've adopted an 1115 waiver that has enabled them to implement CCBHCs across the state. CMS has been quite favorable towards these efforts. They have approved waivers in Texas and Minnesota. They've approved state plan amendments in Missouri, Nevada, and Oklahoma. Really, I don't think there's necessarily a preferred approach. Both the waiver or the plan amendment can equally help a state implement CCBHCs. I think it's more a matter of preference in terms of how states choose to proceed. To give you a few quick details about how Texas has done this, again, they use 1115 waiver authorities to implement CCBHC among other delivery system reforms. They've phased in CCBHCs across the state over several years with the ultimate goal of bringing them statewide. I think they began with maybe around 8 CCBHCs certified initially, and then have expanded it to a few dozen today. Their prospective payment system is under development, so the clinics there are already operating as CCBHCs, but the payment system is the next phase that's coming down the road. And Texas estimates that as a result of this change, they'll save $10 billion by 2030. Again, those savings are predominantly from things like reduced hospitalizations and emergency department visits. You can see the sort of the projections there for how this model can make a dent in that area. In the first 2 years of Texas doing this, there were no more wait lists at any CCBHC clinic. You can see, as I mentioned earlier, the better accessibility of a comprehensive scope of treatment at a CCBHC, reflected in the fact that 40% of clients at CCBHCs are being treated for co-occurring substance use and mental health needs compared to 25% of other clinics. So again, you can see how this payment model is enabling expansions that many clinics have wanted to do for quite some time, but haven't had the resources to support. The National Council is here to help if you are interested in moving towards CCBHC status. We provide support to individual clinics that are thinking about going after one of the grants or implementing the grant that they just received. We also provide supports to states who are thinking through what would our roadmap towards implementation look like? What has this model generated in other states? And how could we move towards this as a state looking ahead? So you can see our website and our contact information here at the bottom of the screen. And with that, I'd like to stop and turn things over to Jonathan.
Okay, thanks, Rebecca. Let me attempt to share my screen here. All right, well, thanks for the invitation to share some of the findings today. So I thought that we would just take a moment to share some of our observations about the types of investments that states and clinics have made over the past few years to meet the certification criteria and become CCBHCs. Talk a little bit about some of the common implementation challenges and how they've been able to overcome them. And hopefully, if we have some time, share a few lessons about what we've learned about the prospective payment models as well. So as Rebecca mentioned, and Ben as well, our ongoing evaluation is for the Office of the Secretary for Planning and Evaluation. And that has included just the 8 original demonstration states. So we're not evaluating the 2 new states that just recently came on board or the SAMHSA funded grant program. But some of the findings might still apply to kind of future CCBHC efforts or similar kind of value-based payment efforts going forward. So there's a lot of slides here, a lot of material, and in the interest of time, I'm going to skip through some things and go over some of this very quickly because some of it Rebecca did a fantastic job of covering. So I'm not going to talk too much more about the CCBHC criteria. You've got the link there if you want to kind of take a deeper dive, and we're happy to answer your questions about it as well. Just wanted to give you kind of a brief orientation to the evaluation that we're conducting. It's really designed with 2 overarching goals. The first being to assess different dimensions of implementation in terms of how states supported the model, the successes and challenges that they've had in implementing that full scope of services, looking at the quality and cost of care, and also experiences of different stakeholders with the model. And then the second goal being to measure the impacts of the demonstration on Medicaid service utilization and costs. So I'm going to focus today on just giving you a few highlights from our implementation findings that might be relevant as you're kind of thinking about the CCBHC model in your states and communities. We're concluding the analysis of the Medicaid service utilization cost now, so I won't be sharing that today, but hope to have those findings to come back and share with you all in the near future. Not going to go deep into our data sources or methods other than to tell you that we have collected both qualitative and quantitative data over time at different points in the implementation of the demonstration to track progress over time and kind of understand the rollout of the demonstration. Primarily, what I'll draw from today in some of the findings come from the progress reports that CCBHC submitted in both years of the demonstration, as well as those cost reports that Rebecca mentioned earlier, and some of our qualitative data collection as well. So again, just want to give you some real high-level highlights of some of the investments that states and clinics have made to meet the certification criteria and become CCBHCs. So really, I think those can be summarized a bit here. There certainly are a lot of other investments that are not captured here, but these are some of the major things that we've observed from the evaluation, and I think they just echo a good bit of what Rebecca talked about earlier. One being the hiring and training of staff to provide team-based care. As Rebecca mentioned, there are some requirements in the certification criteria about the types of staff that CCBHCs should employ, but there's also flexibility in that criteria to kind of design treatment teams in a way that meets the needs of the clients at that particular clinic or in that particular community. Adding behavioral health and expanding behavioral health, physical and rehabilitative services in particular. As Rebecca mentioned, it's not that these clinics were not necessarily providing some of these services prior to the demonstration, but we have definitely observed the expansion of those services in kind of different ways that I'll talk about in a second. The partnerships that Rebecca talked about have also been extremely important. Nearly all of the clinics have developed these partnerships with a range of external providers, both to facilitate referrals to the clinic and referrals from the clinic and to coordinate care with those external providers. And the final thing I'll say is, can't really underscore enough some of the investments and enhancements that were made to the EHRs or other HIT systems to support the demonstration, both to support the sharing of information across providers and those care coordination functions, as well as to capture and report the quality measures that are required as part of the demonstration. And really, what we've heard from states and clinics is that it's been both the combination of the 2-year planning grants that the states received prior to the launch of the demonstration, as well as this new payment model that has facilitated these types of investments. So the next few slides just really give you kind of some brief snapshots of what I just talked about there to kind of dig in a little further. So in terms of staffing and hiring, this is not an exhaustive list of all the types of staff that these clinics employ or have hired, but does illustrate some of the staff types for which we observed some pretty substantial increases from before the demonstration to the first and second years of the demonstration. So in particular, case managers, adult psychiatrists, and peer staff were some of the staffing types that clinics really invested in hiring leading up to the demonstration and in the first year. Don't have to tell you all why it may be more difficult to find psychiatrists for child and adolescent populations, but that was another area where clinics made investments. In terms of the type of trainings that I just mentioned earlier, again, this slide just gives you a bit of a snapshot for the types of trainings that clinics provided in the first year of the demonstration. So nearly all providing training in the areas of risk assessment and suicide response or prevention, trauma-informed care, cultural competency. If you look down the list there, most clinics are also making investments in providing training around primary and behavioral health care integration. And these trainings, do continue throughout the demonstration as well. Again, as Rebecca talked about, there really is an expansion of services under this model. It's not just providing kind of the same services under a new payment model, but there is kind of the addition of various types of services that the clinics may have offered to a certain degree prior to the demonstration, but have enhanced in some way. And again, this just gives you a bit of a snapshot of those services. In particular, as Rebecca mentioned, there has been this expansion of substance use services for clinics that may have been more predominantly focused on mental health treatment in the past, and also expansion to different populations as well. Most clinics are providing some type of emergency crisis intervention directly. About 80% of clinics have their own 24-hour mobile crisis teams. And as Rebecca mentioned, about a third of clinics, in addition to providing their own services, do partner with another entity to provide either some type of crisis stabilization or suicide or crisis hotline. And again, those are typically in states or communities where those services existed, and it made sense to tap into that rather than recreate it at a CCBHC level. I'm going to skip over the partnerships because we talked a good bit about that. Might just say that some of the partnerships with the organizations listed in that second bullet here, urgent care centers, school-based or rural health centers, were a bit less common in the demonstration states or for those clinics, but that was mostly because they were just located in communities that weren't adjacent to those types of clinics or providers. Where they were located and where they had those partnerships, they were really critical. And then finally, I've mentioned the investments in the data systems and the EHRs and other systems. Nearly all clinics did need to make some kind of enhancements to their systems. And in addition to making enhancements to whatever current systems they had, about a third adopted some entirely new system to capture some type of information that their existing system didn't have the capabilities to do. And I don't want to minimize this because this really was a heavy lift for a good number of clinics and for states, but states really did provide a lot of technical assistance and support. And during the planning grant phase of the demonstration, kind of leading up to the launch, they made kind of good strides to be able to build out some of these functions that you see listed here below, and ultimately to capture the information for the quality measures and for care coordination. So I'm going to talk for just a second, slow down just for a minute here to talk about some of the implementation challenges that we've observed across states, none of which I think were really unanticipated, but still are probably good to have on everyone's radar. So in terms of staffing, not surprisingly, most clinics did report that at least one position that was required in the certification criteria was vacant for a period of time. And particularly looking for substance use treatment providers and peer support staff were challenging in some communities. And these weren't really kind of challenges that were unique to CCBHCs, but really kind of common in community mental health services in terms of workforce shortages and being located in areas where maybe rural areas where it was difficult to find those staff. But you know, the clinics were really able to largely overcome these staffing challenges, both because they were able to use the new payment model to offer more attractive salaries, and they also, we heard from clinics and staff that they were also just attractive places to work because people wanted to be part of these models. I talked a little bit about some of the challenges delivering these new services. Again, that was mostly just related to staffing, to finding staff to implement them, as well as some of the challenges reporting the quality measures that really required the build out of their EHRs or HIT systems. I think what we also learned though was that they, in some cases, need to implement new processes of care that are in the criteria, such as new screening, which also kind of feeds into the quality measures. And ultimately, the clinics were largely able to report the measures and use them for quality improvement and found them valuable. And also not unanticipated, some initial billing challenges just as folks are getting oriented to this new way of billing for daily or monthly services and kind of the new processes around that. But clinics were able to overcome that and get paid with help from the state kind of in the first few months or year of the demonstration. And again, just to reiterate, that state agencies really did provide critical support in many different ways through technical assistance around building out data systems, providing kind of quality monitoring and feedback to clinics, as well as in some cases making some changes at the state level to support implementation of the model. So in the last kind of 6 minutes or so, but because I want to make sure we have time for questions, we did just want to share a few lessons about the payment model. So just to recap, say it again, because I always have to remind myself as well, these are the 8 states that we're focused on here. And 6 of those states chose that daily payment model that Rebecca talked about. And 2 states, Oklahoma and New Jersey, chose that monthly payment model where the clinic gets a monthly payment for any month in which the consumer receives services, regardless of how much services the person receives during the month or how many visits they have. And again, there's kind of trade-offs of each model. But I want to talk just for a second about the sort of the rate setting process and what we've learned about the rates that might be applicable for kind of the future of this model and kind of similar models. Not surprisingly, you know, rate setting was kind of a challenge at the outset. Just to reiterate, states set a rate for each clinic. There's not a single rate that applies to all clinics in the state. And so for each clinic, they really got to kind of look at what are the pre-demonstration operating costs before you become a CCBHC, and then forecast what are the costs of these new services that you're going to add, and how many people are you going to bring into the clinic as well, the existing population as well as these new populations that you're expanding to. And so states, again, provide a lot of technical assistance to help clinics complete those cost reports that Rebecca talked about, which fed into the rate setting process. And they recognized the limitations of the available data at the time and kind of erred on the side of prioritizing that the clinics would have financial support they needed to operate, even if that may have meant setting the rates a little bit high initially. So we've gotten some questions in the past about what the rates really are, and are they, have they been enough to cover the cost of services? So there's a lot of numbers on this screen, but just want to kind of show you quickly the range of the rates across states and across clinics within a state. So that daily rate ranged from a low of $210 in Nevada to a high of $403 in Minnesota, with some variation in between. And again, this is sort of reflecting like the local market conditions, as well as kind of the cost of operating before the demonstrations in each of these states. But then if you look at the next two columns, you also see that range of rates within a state. And so again, Minnesota having the largest range from about $269 to $709 in the first year across clinics. And in Nevada, the clinics were paid generally the same rate. And then New Jersey and Oklahoma have those higher rates because those are the monthly, those are the monthly as opposed to the daily payment rates. So on average, it's and those are all the first year rates. On average, those rates did cover the cost of operating in 7 of the 8 demonstration states. But still, in each state, there were some clinics for which the rate didn't fully cover the cost in the first year. And that's what illustrated here on this slide, each clinic being a green or blue dot, depending on the PPS model in the state, and the orange there being the state average. And so what you see is that, on average, the rates are actually exceeding the cost in the first year, but there are clinics that are below that line, meaning that the rates weren't fully covering the cost of the services for those individual clinics. And so in the second year of the demonstration, the states did have the option to revise those rates, a process they called rebasing, based on the cost of delivering care in the first year of the demonstration. So they could either revise those rates up or down. The states listed here did choose to kind of recalibrate their rates for the second year. Most moved in the direction of bringing the rates down to kind of bring them in closer alignment with the cost that they observed from the first year. 2 of the states, Oklahoma and New Jersey, did actually increase the rates for the clinics in their states, and 2 states decided that they wanted just to hold off, Missouri and Oregon, to get more data to inform changing those rates. So I think really kind of taking a step back, the lesson from all this is that it's difficult to predict these first year costs when you're adding new services and expanding to new populations. States often don't have the best data, and clinics don't often have the best data kind of going into this to make those predictions. But as we're seeing over time, it kind of takes some time to align those rates with the cost, and states have been able to kind of learn from the first year of the model to kind of better align those rates and cost over time. So you might not want to make decisions about whether this is all working just based on the first year cost, as the states and clinics are really learning from the model. So I'm going to stop there. Stay tuned for future findings from our evaluation around both the quality measures and the impacts of the demonstration on service utilization and cost. Happy to answer more questions now. There's also several pretty dense reports, pretty thorough reports online if you want to kind of take a deeper dive into any of the evaluation findings, and I'm happy to answer questions.
All right, thank you so much to both of you. We have now reached the Q&A portion of today's webinar. So everyone, please feel free to submit your questions for our presenters by typing them into the Q&A feature. I'm going to go ahead and start with the first question, which was, will this presentation be available to download? Yes, it will be available to download on our website in a couple of days. I'm going to go to the chat because I know we had some questions in the chat. The first question is Massachusetts one of the Medicaid demo states? And I did see another question in the Q&A feature about which states are included in those 10 states.
Sure, I can repeat the list. It's also in the slides we saw earlier, so the question may have been answered, but just as a refresher, the original 8 demonstration states were Oregon, Nevada, Oklahoma, Missouri, Minnesota, New York, Pennsylvania, and New Jersey. And then Michigan and Kentucky were recently added. So no, Massachusetts is not one of those not one of those demonstration states. I will say, as states are, National Council, our team is in a lot of conversations with different states that are really interested in exploring whether CCBHC could be right for them. And when we had similar conversations with states 5 years ago, as they were considering whether to go after participation in the demo, so much was unknown. When states would ask me questions, quite often the answer was, well, we don't know. You could, you'll propose something and see what you can do, see what works, and adjust as needed as you go along the way. And I think you heard from Jonathan about some of the ways that states were adjusting as they went, around the payment rates and the billing structures and the data and quality reporting and, the EHR system upgrades and so on and so forth. And the great news is that we've learned so much from those 8 states that went first. So states that now would consider moving after, going after CCBHC implementation are in a much, much different position where they can see what has worked really well in other states. They can learn those lessons and they can have hopefully a much more streamlined experience of implementing the model. So if you're in a state like Massachusetts that isn't already there, I think there's certainly a lot to be learned from these prior states that could help pave the way for new states to adopt it.
All right, thank you so much, Rebecca. It looks like we don't have any further questions in the Q&A feature or in the chat. I just wanted to open it back up to you and to Jonathan to see if you had any final comments or remarks before we go on to evaluation.
I guess I would just repeat that National Council would love to continue the conversation with anyone who might be interested in exploring the CCBHC model further, whether that's answering more questions about what it looks like or helping you think through what your next opportunity to apply for a grant might be and how to get ready. We're available to support, so please don't hesitate to reach out to us. Our goal is to make sure that as many clinics as possible can become CCBHCs and that they can all be as successful as possible as they do it.
Yeah, and likewise, probably on that same note, I'll just say if there's anything you'd like to learn more about the evaluation, or perhaps how the findings from the evaluation could be applicable to any decisions that you're trying to make, please don't hesitate to reach out. I think my email contact information is at the end of those slides there, and we'd be glad to chat.
All right, thank you both so much. Okay, we've come to the end of our webinar today, everyone. The Southeast MHTTC would like to thank you for your participation in today's event. We value your feedback and invite you to evaluate this event by completing the brief SAMHSA required survey, visiting the link presented on your screen, in the chat box, or by scanning that QR code. Completion of this survey will provide information to SAMHSA and assist us in planning future events like this one. Afterwards, you will be automatically redirected to additional questions from the Southeast MHTTC regarding the impact of this event on your knowledge and skills. There, you will have the opportunity to download a certificate of attendance for your records. Please allow about 5 to 10 seconds for your browser to redirect you. Again, our center appreciates your participation and feedback. Rebecca and Jonathan, thank you so much for joining us today and for providing this amazing information. We hope that you all will join us for future events. Please visit our website to learn more. And this will conclude today's presentation.
Okay, thank you.
Thank you.
Thank you.